We are super proud of tonight's offering. Did I mention yet that this is our biggest event ever? I'll keep saying it. Before Rachel Suckle introduces our speakers and explains how the session's going to go, I want to say four things. First of all, mute your microphone. Much as we like the idea of 1,000 people breathing heavily in unison, it's kind of distracting. We think we've got you muted, but please do it again. WebEx bingo players, you can cover that square. Okay. Number two, yes, this presentation will be available after it's over. We're recording the video, we think, but definitely the PowerPoints will be available on our AADMD website and our COVID info page. And I think that's WebEx bingo square number two. Third, please consider joining AADMD as a member. We have various levels of membership for students, for practitioners. Information about that is on our website. And if you're not sure about joining after tonight's session, we would really appreciate it if you would consider making a donation of whatever size you're comfortable to help us keep doing what we do. You're going to see information about that in a moment and then later on. Last thing is we have a quick poll, and that's you should be able to see that now. I think I can see it, and the first question that you should be able to see is what best describes you. If you can see that question, please answer it. I'm getting all kinds of text messages, and I don't know what I'm supposed to do besides tell you to answer the question. In a moment, you'll see the next question, I believe. Actually, the next question, maybe you have to scroll down for that. Someone should help with the questions because I'm not sure how to lead this. Alan, could you jump in, please?
I'm sorry, the second question, the other question didn't come through. My apologies.
So we're just going to stop with that one? If that's the case, then I think, Rachel, you can take it from here. Thank you. I'll be joining the panel later to help answer questions.
Welcome to Virtual Grand Rounds. My name is Rachel Bockwell, and I am a first-year medical student at the Geisinger Commonwealth School of Medicine in Pennsylvania, and this year's AADMD Virtual Grand Rounds facilitator. For those that are new, Virtual Grand Rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across the spectrum of experience levels. After this meeting, we will be sending out a survey for feedback on how to improve these meetings. If you have questions throughout the presentation, you may write them in the Q&A box on the sidebar, and we will go over as many as we can. Please make sure to send them in the Q&A box and not the chat box. If we don't get to your questions, we will have them on the website afterwards. The Q&A will be hosted by Dr. Steve Sulkas, President of AADMD and Professor of Pediatrics at University of Rochester Golisano Children's Hospital. Dr. Seth Keller, a neurologist specializing in IDD, past president of AADMD and co-chair of the National Task Group on Intellectual Disabilities and Dementia Practices, will also be helping answer questions. Visit our coronavirus page on aadmd.org. It's a great resource if you have any questions. This presentation is made possible through the support of University of Pacific's Arthur A. Dugani School of Dentistry in San Francisco. And now it gives me great pleasure to introduce today's speaker. Dr. Jeffrey Weinberg is a president of pediatrics in infectious disease at the University of Rochester Golisano's Children's Hospital. Dr. Weinberg's practice includes all areas of pediatric infectious diseases with special emphasis on pediatric HIV/AIDS medicine, clinical immunology, and use of immunizations to prevent disease. He is a member and past co-chair of both federal and New York State advisory panels on pediatric antiretroviral therapy and management of HIV, and has worked closely with the Centers for Disease Control as well. He has written nearly 60 textbooks and published more than 150 papers in the field of pediatric infectious disease and immunology. Dr. Weinberg and his wife have 3 adult children, one of whom has special needs. Thank you for presenting, Dr. Weinberg.
I don't have any financial conflicts of interest to declare. I do usually have to say that my research is funded by CDC, but nothing I say in this webinar is meant to represent them, the Public Health Service, or the Health and Human Services Department. And I did want to say that knowledge about COVID-19 is increasing so quickly that it may turn out that anything I say in this webinar may be out of date or even untrue next week or next month or next year. So goodbye, and thank you for having me tonight. All right, that was a joke. Video jokes don't work very well. So the outline I thought of what I'd mention is just a little bit of a review of COVID-19, or as the virus is called, SARS-CoV-2. The infection with this virus is called COVID-19. So a little bit of history and virology about coronaviruses, and then focus on the disease in adults, how it might be different in children, a tad on transmission and prevention, and really the sort of the meat of tonight is what is so different, or what might be different about this condition among those living with IDD. So human coronaviruses have been known since, well, the human ones have been known since the 1960s, animal coronaviruses since about the 1930s. So there were 4 coronaviruses that we in infectious disease talk about, and they have these horrible letter and number names, 229E, OC43, and you can see the other 2 there, NL63 and HKU1. And basically, we learn them as common cold viruses, and so people tend not to pay attention to them too much. They cause a lot of, maybe up to a fifth or a third of common colds. And we know that immunity to them is not perfect. That's why we can get common colds year after year. Although some of that, of course, is because we're getting them from other viruses like rhinoviruses. So most of the time we think of coronaviruses as causing upper respiratory tract infections, URIs, and sometimes lower respiratory tract infections, particularly in those who are immunocompromised, transplant patients, cancer patients, folks like that. And we don't really have any vaccines or any antivirals that work against coronaviruses, against the 4 older ones. And that's going to come back to haunt us in the days of the 3 newer ones. And there's a zillion more coronaviruses that infect animals that I, as a pediatric infectious disease people, never really paid attention to. But these things are large viruses, they're RNA viruses, and they're kind of all over the world. And the problem, and so we'll come back to how they jump from animals to people. This is now a famous picture that the CDC drew. It's fairly anatomically correct. There are different spike viruses and different antigens. This is a different type of cartoon showing the RNA inside it. But everybody sees this one now in all sorts of presentations, including this one. So these old coronaviruses, well, in children, perhaps in children in the hospital, like children under 5, let's say, we think it's about 8 to 10% of those kids who are in with lower respiratory tract disease, that is bronchiolitis or pneumonia or croup, might have a coronavirus. And they're found all over the world, both in tropical and temperate regions. And they're concentrated as one of the winter-spring colds, although sometimes you see them year-round. This is scary when we talk about the new coronavirus because unlike what some people in the administration have said, the federal administration, that it'll disappear in the winter, that's not, disappear in the summer, that's not a given, because you can see coronavirus year-round. And most of us as adults actually have been infected in the past. If we take antibody samples in your blood, you can find some antibodies against coronaviruses, but they may not cross-react with each other. So one coronavirus infection doesn't protect you from another one. We do think that with these older coronaviruses, we think that they were more often asymptomatic in young children, and the incubation period is about 3 days. So why do I keep calling them old? And that implies that there must be something new. And of course there is, otherwise you wouldn't have invited me. So the 3 new ones are the SARS coronavirus, which caused SARS, or severe acute respiratory syndrome. This was a multi-country epidemic, almost a pandemic, that caused 8,000 or so cases, with a pretty serious case fatality rate, 10% mortality, that began in China and quickly spread to about 32 countries over 3 months, back in 2002 to 2004. But with good isolation and sort of for somewhat unknown reasons and good isolation, it has disappeared and gone back to wherever it was among animals. And so we don't have SARS right now, the original SARS-CoV. About a decade later, in 2012, people in the Middle East, in Jordan and Saudi Arabia, Syria, Bahrain and other countries there, who had been around camels, mostly camel handlers or Bedouins who are using camels for transportation, were infected with another coronavirus, distinct from the old ones and a little bit distinct from SARS, and that was called Middle East Respiratory Syndrome. And that actually spread to a lot of countries in Europe and the Middle East, but really didn't make it here. And mostly it's continued to the present, but it's mostly just scattered folks out in the desert or handling camels. But it was a pretty vicious coronavirus. It caused perhaps fewer cases, only 2,500 cases than the original SARS, but a heck of a lot of mortality. And now we see a new coronavirus, which originally was called nCoV-19 for novel coronavirus 2019. We're not very adventurous in the way we name viruses. And we've renamed it SARS-CoV-2 because it's really one of these new coronaviruses related both to MERS and SARS more than it is to the old ones. And the disease that SARS-CoV-2 causes is called COVID-19, for coronavirus infectious disease from 2019. And it's certainly with us now in 2020, and we don't really know how far it'll go. But it has been a far more troublesome illness, as you can see in the million cases or more around the world. Essentially, all countries in the globe have reported at least a few cases. Thankfully, it's not, if that was 34% mortality like MERS, we'd be in real trouble. But even 2 to 3% mortality is a lot of potential for death. So this is quite the scary pandemic. None of us really, well, there's probably somebody somewhere who expected this. Most of us in the field expected this to happen with one of the swine flus or avian flu. So we've been talking about pandemics for a while, sort of like climate change. Not everybody in government has listened to it. But now we have a pandemic with something we didn't really know much about, which is this new virus. So where do these things come from? Well, it turns out a lot of them come from bats. And SARS-CoV was thought to be a bat virus that may have then infected these little wild cats called palm civets. And in various markets in China where they have lots of food and lots of live animals for food, people there crowding, and also bats can fly in at night. It's like a mixing bowl for viruses. So it's thought that the bat virus jumped to this other mammal, this small cat-like creature, and that may have infected people. And with MERS, I already mentioned it was in camels, but it's thought to have been the bats, different species of bats infecting the camels. We're not sure where this novel coronavirus has come from, the SARS-2-CoV, although some scientists have said that it was from this little guy called a pangolin, which is kind of a anteater with scales that's in Malaysia and the Far East and in China. Apparently is sold in these markets, again, for either meat or medicinal purposes. And there's some argument about whether the pangolin at fault But I thought it was kind of a cute picture, so there's your pangolin there. But it's really still a question mark. So I mentioned China in all of this for reasons that aren't absolutely clear, but may have to do with crowding of millions and millions of people and particular cultural tendencies, such as the markets with food, with so-called wet markets with live animals, some dead animals, and some environmental sources like bats. We see a lot of these epidemics of different flus and different viruses start in Asia. And we're now seeing many reports come out, and I want to turn to this section of the talk to just talk about a little bit of adult medicine. And then we'll get to the pediatric medicine and then to more IDD considerations. So this is one of many papers that are coming out now from China. This one was published in the New England Journal, as you can see. And I'm sorry, the print is going to be small, even in a webinar when you have your own phones or your own computers that you're watching. But I'll just walk you through it. This was from this paper that's actually still in press, although it's been printed. Or maybe it just came out, I guess, in print. The important points that I see here are this is a table of all the different characteristics of folks who they had early in the epidemic in China with COVID. This particular paper is a nice one because it has almost 1,100 patients. Their data are here in the center, and they've split their patients by non-severe and severe. That's the next two columns. And if you were to read this paper, or if you could see the figures, I would say the important points are in the age distribution here, just about everybody, whether they're severe or non-severe, are adults. So they're virtually all over 15 years of age. The kids under 14 years is less than 1% of their 1,000 patients. So that's important to me as a pediatrician. It's, as an internist, you would be, as internists are right now and family practitioners, in big trouble because it's mostly adults who are getting this condition. You can see that in the severe disease, if you compare this column to this column, the severe disease goes up, up, up as your age goes up. So here in the young people, in fact, young people here, the non-severe was more, 57% of non-severe people were in the younger age group, whereas only 13% were above 65. But if you look at people who had severe disease, it was more like double that. It was 27% of folks who had severe disease were elderly, with a definition there, which isn't very elderly, as I see it now, of greater than or equal to 65. And some of the other stuff is of interest. The biggest interest to me is you got sick about 4 days after the presumed exposure. And this is a very long table, so I split it into two. But the other important points, if you compare the non-severe guys, the severe guys or gals, or all the people infected or diagnosed with COVID, about 50% of them had fever on their diagnosis, 70% had a cough, and 40% complained of a pretty significant fatigue. That's right here, 38 to 40%. 20 to 40%, depending on whether you're talking about, it's a little lower for people who don't have as many symptoms, but the people who are already sicker, about 40% of them have shortness of breath. And although we've read in the newspaper that, oh my, we have to think of this when people have throwing up or vomiting or abdominal pain, actually very few of them do. So 95% did not have diarrhea, 5% did. And what's important, I think, for our group right now for this talk is that in this initial case in a series of 1,100 people in China, very few of them were said to have had either immunodeficiency, which is an interest of mine, or intellectual or developmental delay, which is another interest of mine. But the trouble is, you don't know whether these authors of this paper actually asked if anybody was intellectually delayed or developmentally delayed. They did put immunodeficiency down. There were 2 patients out of 1,000, but they don't define that further. So we still don't know from this paper how it's going to affect our population of interest. They did state in that review, this is a continuation of their data, that about the median age that they were seeing in their hospital and in their cases was about 47 years. So again, an adult distribution. A bit curiously, although not unheard of with other conditions, it's a little worse if you're a male than a female. Females being the stronger sex, as I'm sure everybody will agree. And their most common signs and symptoms, as I mentioned, was this trio of fever, cough, and fatigue. And when they would do x-rays, they wouldn't always see anything early on, but if they would do chest CT scans, they would see various infiltrates and what they call ground glass opacities, which are very common in patients diagnosed with COVID, but not very specific if you're used to looking at a lot of CAT scans. And these people seem to have a low lymphocyte count. So lymphocytopenia was probably the biggest laboratory marker. There wasn't much else that they could cull out of their 1,000+ people in China. Recently in JAMA, the first 21 cases in and around Seattle were published. And they were skewed because many of them came from a skilled nursing facility outside of Seattle and were hospitalized. And so the average age of these 21 patients was 70, as opposed to 47 in sort of a general population look. But again, they had fever, cough, and shortness of breath. Now, they had a lot more shortness of breath, but it may have been because these people were elderly, and it's unclear if they were sent to the hospital very quickly from their nursing facility. So they may have been already sicker. And they had quite a bit higher mortality. But again, it's hard to know if that's because they were farther along in their disease or just farther along in their lifespan. So that's what we can get from the first 20 or so cases that were reported in the United States. More recently, the Chinese, unfortunately for them, their case number, just like with ours in New York, case number has gone up through the roof. So that first article talked about 1,000 people. By mid-February, they had already had 72,000 cases in China. And in late February, they published a paper in JAMA that was sort of a summary paper that talked about these 72,000 cases. And I'm going to focus on just 45,000 of them that were confirmed by PCR, because I think some of the other 30,000 plus cases may well have been COVID, but they may have been other forms of pneumonia who were just called COVID because they were caught up in the epidemic. But of these 45,000 confirmed cases, which is still 45 times bigger than the other paper, it gives a pretty good distribution of the ages that matches what we have said before. Most people are adults, so 87% were in the 30 to 79-year-old age. A few percent were in the older than 80 age, which I'm not sure how much of the Chinese population is elderly. This is apparently different in Italy. That's why Italy has so many deaths and older. It's thought that one reason is because they have a comparatively elder population in Italy compared to other nations. But in any case, you can see how it was not very common in younger people. And as you get into the pediatric age group, thankfully for me as a children's expert, it was actually quite rare. Unfortunately, if you're over 80, the case fatality rate in this Chinese series was high. It was almost 15%. But if you average everybody together, it was about 2%. And that's the figure that buzzes around in the newspapers. Yes, this fatality rate of 100 people who get COVID, about 2 of them will die. And that's because there's so many who are down in a sort of healthier age group where they seem to do better. And indeed, in these, I think this reflects the 45,000 again, 80% of them or so were judged to have mild disease. Mild disease meant you could either go home or you might have been in the hospital, but you weren't very sick. Severe disease meant you were hospitalized, maybe getting oxygen, but you weren't in the ICU. And critical meant you were in the ICU and having multi-organ failure. And that pretty much correlated with age as well. Now we're starting to get some information from adults in the United States. So from February in the last slide, now we're up to April 3rd of 2020. This is a table that came out of the federal government from Morbidity and Mortality Weekly Report. Again, it's a bit of a long table, but I thought it was interesting because, at least in this country, the federal government does try and look at people with underlying health conditions. And this is a table from all case reports or all diagnoses of COVID-19 in the United States, whether that had been reported between February 12th and essentially the end of March. So there were about 55,000 people, cases that they didn't know the status of their hospitalization. 1,000 were in the intensive care unit, 5,200 hospitalized but not in the intensive care unit, and about 12,000 people not hospitalized. So of the data, it was almost 75,000 people in the United States that they had tried to get data for. And this was specifically looking at underlying health conditions and comorbidities. So diabetes turns out to be about 10% of comorbidities. Chronic lung disease, cardiovascular disease, about 10%. Not hitting our immunocompromised patients very much, about 3.5%. Chronic renal disease, about 3%. So all of these are known risk factors that we take from influenza in the past. These are risk factors for severe influenza as well. And here, finally, we're starting to get some data on neurologic disorders, neurodevelopmental disorders, and intellectual disability. And thankfully, at least in these first 75,000 patients, for what was known, there were very few of them. It was less than 1%. When you look down, when you look at the footnote, even though the category is neurologic disorder, neurodevelopmental, and intellectual disability, most of those folks had neurologic conditions. There were very few that were actually listed. Most of them had, here's the definition: dementia, memory loss, Alzheimer's disease, 17 out of the 52, Parkinson's, migraines, or stroke, about another dozen. I guess here's autism was 2 people on the autism spectrum disorders, a couple people with intracranial aneurysms, neuropathy. So as far as we can tell, at least in the first analysis of US cases, I don't think we can say that intellectual disability, that people living with intellectual or developmental disabilities were overrepresented in this terrible illness. And that's good news. But of course, data may change as we get more. This was a first pass analysis. And it didn't look like they were overrepresented in ICU admissions necessarily either, compared to some of the other risk groups. So I was happy to see that. When we look, so that's sort of my survey of adult COVID disease. I thought I'd spend a few minutes on pediatrics and contrast the points, and then finish with some comments about the IDD population. In children, this is again the first big group that came out of China. This is COVID-19 in children, which was 2,141 cases. Again, only 731 confirmed. So the blue circle is, if I just look at the confirmed kids, here the median age of children who actually are infected is 10 years of age, although clearly there are less of them infected than adults. And oddly enough, it's just like the adults. There's still 60% or so boys and 42% girls. So I guess females are stronger, even the stronger sex, even from birth. And severe disease was uncommon. So again, most of these kids had asymptomatic mild disease, some with moderate disease, very few, thankfully, with critical or severe disease. Again, the median incubation period was about 3 days, and that was, there were some differences in the suspected versus the confirmed, but we don't have to go there. And again, the severe disease, it was rare, but if you were going to see severe disease in children, it tended to be in infants and toddlers. So here you can see this is age group. Each line represents a different age group in pediatrics in children. And asymptomatic, mild, moderate, severe, critical numbers with percentages in the parentheses. So of all critical illness, that's the ones that go to the ICU or have organ failure, half of them were infants and toddlers under a year. Whereas only 7% of all asymptomatic, or well, let's flip it. If you go over here to mild, you get most of the mild cases are in older kids. So infants were perhaps hard, but not very common, luckily. And whether you were confirmed, suspected, or had the total, which is in whatever color that is, my color vision isn't the greatest. The blue is the confirmed, and these other guys are total and suspected. It's about a 3-day incubation period. And now that it's April of 2020, we're finally getting the first United States pediatric data, just as we saw in adults. So this came out in yesterday's MMWR as an early release, just as I was making these slides up. So it was very convenient. And the data from the government are that as of April 2nd, there have been 239,000 plus cases just in the US of COVID-19 illness and 5,400 deaths. And of that, there are about 150,000 had enough data where we could tell their age with precision, and only 2% were less than 18. So again, very much like the Chinese experience. And yet, if you say, what's the what proportion of the population in the US are under 18? It's a pretty big chunk. It's 22%. So a fifth of the entire US population is under 18, yet hardly any of them are getting this condition. The median range of those infected in the US has been, the median age, has been 11. And so far of this set of kids that were analyzed, 91% had exposure to either a parent either a patient or a parent who was infected in the household or a known patient for the community, and just under 10% of them had traveled, and that was their exposure. And there are very few pediatric deaths as opposed to the unfortunate slew of adult deaths that we've all heard about. So it tells me that COVID does infect children, and if you look at the cumulative number of cases, it is slowly going up in the United States. So each, maybe 200 or so every week. But that's compared to thousands and thousands and thousands of adults. So still curiously low in children. When children do get sick, they are pretty much like adults, although their fever, cough, and shortness of breath sort of trio are less common than in adults. Now, whether that's because if we're looking at infants, they can't tell you they're short of breath, or they can't tell you they have a headache or nausea. But whatever it is, the fever, coughness, and shortness of breath as a combination is in about 3/4 of children, where it's almost universal in adults. And we're still seeing less myalgia, less headache than adults. And thankfully, it's still rare to see GI signs or symptoms. So physicians would have asked me, well, this kid has diarrhea. Don't you think it could be COVID? Well, not very commonly. You can never say never, but it's not it's not high on my radar screen. And I think I may skip this. This was a tall slide that didn't fit. I'll just say that it is trying to show you that infants are more likely hospitalized. So these are the kids under 1, kids 1 to 4, kids 5 to 9. The black bars are being at home, not hospitalized. The blue bars are hospitalized. And thankfully, not many are in that bar, which is ICU care, although proportionally more infants than other children are. Okay, how is this thing transmitting? Well, it's by droplet spread in community settings. That means these are small micrometer-sized droplets that are such as those in a cough or a sneeze. They do move through the air and can move, but they tend to fall out because they're droplets sort of like raindrops, and they drop mini raindrops, and they will fall from gravity. That's good because it means they're not going to shoot farther than a few feet, but it's not so good in terms of that means it could contaminate surfaces, which we in ID call fomites, for a few hours. So toys in the daycare, computer screens, bank machines. If somebody sneezes on the bank machine screen and then you're the next one to put your card in, that could be a transmitting element. So the way you prevent that transmission is social distancing. And 6 feet was chosen probably because it's twice times 3 feet. So it gives you 3 feet plus some extra room. Good hand washing, which is, which was part of my prevention regimen ever since Dr. Semmelweis in the 1800s, but we had sort of forgotten that. I heard the president say the other day, who knew hand washing could solve so many things? It's like, really? But in any case, hand washing and using a mask should prevent droplet spread for the most part. And aerosol transmission, which is long distance transmission through the air, such as we think of with measles or chickenpox or tuberculosis, really is much less relevant. Everybody's afraid of it right now because a 2% death rate is still a lot higher than influenza had, but it's really only relevant for medical procedures in the hospital, intubation, extubation, open suctioning of deep tracheal suctioning, things like that. Things you're not going to see in the community, things you're not even going to see in most folks living with IDD, although those on home ventilators, it is a concern. So why is social distancing so important besides protecting you? Because contagious diseases, and I don't have time to go through the math, and you don't have interest to listen to it, but there's a whole set of mathematics about contagious diseases. And it's sort of like the old, it's exponential doubling. So if we think that this person's infected, and let's say with the SARS virus, you infect 2 people on average at a time, and after about 30 days, you may have infected 400 people. But if you reduce that by 75% by social distancing this person so that even though he potentially could infect 2 people, but there's nobody around him because he's distanced himself, then after 30 days, there's no exponential expansion. So this is why we think social distancing is so important. And there are lots of different posters. This is one that came from Britain about how to work from home, use less public transit, try not to visit, don't socialize. And we've had some cutesy ones from the University of Rochester. I particularly like this one. I don't know if this one was official or this was a joke, but it came out on email. Are you at home? Yes. Good job. Stay there. If you're not at home, go home. Are you home now? If you're not at home, go home again. And then finally, you're in a good job and stay there. And of course, this is our mascot, Rocky, the yellow jacket from the University of Rochester, who now has been enlisted in carrying soap and washing his little yellow jacket paws, and also telling us to stay 6 feet apart. And all of this is to reduce that mathematical expansion, which is really, in graphic terms, is what everybody's talking about. What does it mean to flatten the curve? So that means you try and move this gigantic, critical, chaotic epidemic. If you can spread the transmission over a while, yeah, it's a pain because it goes for over a while, but you don't have overloaded hospitals and chaos. So what's different about COVID as we finish up here? What's different about COVID-19 among those with intellectual or developmental delays? Sad to say, I'm not sure I have any data for you here, but that never has stopped me from talking. So, as Steve Sulkus knows. So here are some things that I would bring up, and I would I'm very dying to hear what my panelists would say about this, because I think we don't really know what to do about COVID with our population yet of folks with IDD. But I can think of a couple things. First of all, many of them, because of have comorbidities of either the usual influenza risk and now COVID risk items of obesity, neurologic disease, respiratory disease, whether it's because of medical problems causing home ventilators or psychoactive agents that are associated with increased weight gains. Lots of folks with IDD have communication difficulties, so it's tough for them to tell us as physicians the symptoms, and it may be tough for us as physicians to explain to them what we're doing. There's a lot of what I call self-care morbidities. By the nature of IDD, one might be partly or entirely dependent for others for self-care. That both doubles your exposure to more people if you have shifts of people coming in to help care for you. And it may also lead, depending on the care setting, to lesser degrees of hand washing. And for those who are in sheltered apartments or sheltered homes or group homes, it may be physically impossible to socially distance, depending on how the home has been constructed. There are also some intellectual comorbidities. I think this happens with typically developing people as well as people with IDD, that just this whole concept of sudden social distancing and quarantine is hard for anyone to grasp, much less those of us who are living with IDD. And those living with IDD, and I put up my son as an example, are not good with changes in routines. And in this business right now with COVID, not only are we rapidly changing routines, but we're pretty radically changing routines. One day he's over at my house visiting, and the next day he's stuck in his care facility, and I'm not allowed to come in, and he's not allowed to go out. And then there are the thorniest issues are what I call the ethical issues with pandemic care. I think we'll get into this in the panel too. It's very, very scary to think about running out of ventilators, as we hear in the news every day. You can't just throw up your hands. Medical care has to be allocated somehow. But we have to remember to allocate ventilators and other medical care equipment equitably, fairly, and rationally, both because of good morals and good ethics, but also because of federal law. The American with Disabilities Act states quite clearly that you can't just, that discrimination against disabilities is not tolerated in this country. And the American College of Physicians, many state governments, many bioethicists have recently published statements all around this area, trying to make sure that various populations, either socioeconomic, elderly, or people with disabilities, are not unfairly treated or judgmentally considered as excluded because maybe their life wasn't the same as somebody else's life, and therefore maybe we should give a ventilator to somebody else. So we're trying to caution against that. And the way I think we have to do that is with medical resource triage. And this is the same as anybody who watched MASH or who watched Saving Private Ryan. You know what triage is. Combat physicians for a long time who are under the gun literally under the gun, have to decide who to give their resources to. And over the past 20 years, there's actually been a fair amount of papers on this, but they've been kind of buried in the bioterrorism, chemical terrorism, and pandemic flu literature. And thankfully, we didn't have a lot of bioterrorism or chemical terrorism. And so now the first real test seems to be COVID-19. And I think it behooves us all to get it right. Otherwise, it's really going to be a disaster. And so these papers already talk about how you can't just say, as I've seen some people say, well, whoever gets to the hospital first gets the first ventilator. That's just inappropriate and wrong for many reasons. And it's hard for a doctor to say, well, we'll give it to the sickest first. because if they're sickest first and they're already sick and going to die, that goes back to combat triage. If you're just about going to die, then if you're already dying, there's no sense giving the ventilator to unless you think you can be saved. So there needs to be an appropriate balance of patient need, some objective, as much as we can be, judge of effectiveness. That is, okay, this treatment's going to help this patient recover. And some objective prognostic evidence, not just how many life years you have expected, because that can be inherently biased against people with IDD because they're not very good life expectancy data that aren't 20 years old when we didn't. I mean, it's a big circle. We didn't do very good medical care 40, 50 years ago for folks with IDD. So, of course, they didn't live as long as they do today. But that, if you're looking up in the books and it says syndrome, whatever it is, doesn't live very long, that could be totally wrong. And then you get a bias. So there is actually a framework that was published in Chest last year. It's been cited recently by several bioethicists like Bernard Lowe. It's been taken up by University of Pittsburgh as a policy, and I don't think we have time to go through it all, but I found it interesting that they try to assess medical points as to how sick one is. The long-term survival is very gross. It's just, do you have a fatal cancer already that's going to kill you within a year, or you have none? And then life cycle considerations, pregnancy, some extent age, but in a very broad range. So you're not just saying, oh yeah, a young person's better suited for this ventilator than an old person. It's more like, well, what they call it is if you haven't had a chance to live through many life cycles or life stages, then that's less fair to have, a potential death then. And then you throw in all these points, and when you get ties, you look at other things, and you have an experienced triage team that is very distinct from the clinicians, from the family, that to make such hard, terribly hard decisions, but also to communicate with the family and the clinicians, to not just come in like some panel of a grim reaper. You're constantly on the move, talking to family, talking to clinicians, reevaluating scores. And that's a possible framework for how we could operate in a disaster. Whether this is happening or not in New York City, I assume it is. I don't know if they're using exactly this, but I assume they're having to use something. And then there are other things that how COVID is going to affect folks with any disability. Many people have pharmacy needs, and right now the government and the insurance company are trying to ease the restrictions on, you can only have 30 days or you can only have 90 days. We do need to keep immunizing them. We're not canceling all visits, but we can do a lot of telehealth and telemedicine visits so people don't have to come in. You have to remember if they're all cloistered in a care home, you have to remember that somebody's got to go out and shop. Otherwise, everybody's going to have food insecurity. And I decided not to concentrate on lots of different references, but I did list some here on just how to try and talk to people about outbreak disease. Mostly they're about talking to children, not necessarily IDD specific or IDD specific adults, but there are some good things from National Association of Pharmacists, from the Mental Health Services Association, from Disability Rights Education Defense Fund, particularly on equity issues, and of course the AADMD website. So for now, that's my last PowerPoint. I often use this, but maybe it was inappropriate for a talk on a pandemic, which has some amount of mortality, but about where your interest level and the rest of my talk is about right there. So I'd be happy to answer chat questions, and I'll be breathlessly awaiting our other panelists.
Thank you, Jim. It was great. We really appreciate that. That was very, very informative. And thank you for bringing up so many issues specific to the world of Developmental Disabilities.
Thank you so much, Dr. Weinberg, by the way. It's really informative. So our first question is looking at the slide about underlying health conditions in 7,100 adults with COVID-19. And participants asked, how reliable is that when testing was so limited? There is no way to truly know the denominator.
Well, testing has been, I mean, these are early data. I'm sure there will be more data coming later. I think testing has been a big, that would be an hour discussion in itself. You don't know how much information is there unless you have a perfect test that you can test everybody with. The tests are good right now, but they're not, we don't have enough to test everybody. So I think this is just the initial tip of the iceberg. But I think the early data are important as a signal. I don't think we're all, I don't think folks with IDD are going to harder hit a representative proportion of the population given these early data. But you're right, things could change because that's only 7,000 out of the 230,000. But these are hard studies to do. We have 230,000 cases. They're spread in all hospitals all over the place. And even the federal government and the CDC can't read everybody's chart at once, or the charts aren't available. So we don't have a good federalized system to get instant reporting. About the only instant reporting you can get are ICD-10 codes and death certificates. And that's very gross.
And as we've discussed often before in this forum and elsewhere in AADMD, people with developmental disabilities often don't have those conditions listed in their problem lists in their electronic records, so they can be undercounted for that reason. On the other hand, it was interesting, I didn't see anybody with Down syndrome, anybody with cerebral palsy in the early data that you were able to share. As we know, some of those folks have more specific health problems.
Yeah, well, I think we're going to have to wait for some. I mean, the problem with the early stuff out of China, and I don't mean to be pejorative. I know very little about the Chinese medical system, but I don't know what their list, if they list Down syndrome or different IDDs in their problem list the way we would try to.
We know for certain, this is Seth Keller, we know for certain in the United States that IDD overall in depth is being reliably indicated? I don't really know if it is. I mean, I know it is because you showed some data, but I'm a cynic by nature, and I'm really sure that reliably by county, by state, nationally is being really collected. So I don't know. I would assume that, I don't know. And also because of congregate living and some people in group homes, obviously we hear a lot of stories about group homes and risk of COVID-19 getting into the group homes and others, and those reports are there. I think the data is going to evolve in the future as we learn more. I would imagine so.
Yeah.
So I had a conversation with the CDC. I know that Alicia Pisano, I think she had made a comment about Special Olympics and working towards trying to communicate with CDC. Is we have to really make sure that the data is being collected so we can learn. I mean, part of it is learning now on how people are being affected and how access to quality care service is going through the bioethical issue. Are really they getting equitable care? And if we're really not collecting accurate data, you don't know. As everyone may have heard, the African American data that came out today, that they're higher risk of getting it and dying and all that. So we need data. I mean, not to hear data, but we need to know. And the other part, the data that we should be aware of, is the family member direct report on how they themselves, the workforce, how they're being affected by the COVID virus.
One other group that may be able to help us with data worldwide is Special Olympics International. They've got connections all over the world, specifically related to people with developmental disabilities, and they're going to be collecting reports as they go. So they're going to be an important partner in this, I'm sure. Next question. Is there another question?
Yep. So our next question is, for those that are high risk with chronic lung disease, is the best way to diagnose by X-ray, or are the swabs that are being performed viral panels?
I think, well, the viral panels do not have COVID on them, right? The usual viral panels that we use for influenza, respiratory syncytial virus. But specialized PCR testing of COVID, which is generally done in the nose, in the nasopharynx, or sometimes partway up the nose, those are really the best tests. The Chinese have done a lot of CAT scans in their reports. I think their medical culture is to go for CAT scans a lot, but scans do have expense, and particularly radiation. And that's not my favorite way of diagnosing. I don't think that's how we would, I think we would much prefer to get diagnostics by the nasopharyngeal or nasal PCR. You can find the virus in the throat, but throat swabs are thought to be less accurate. And so right now, the best test is the PCR test. Blood tests are all up in the news. I don't think they're, I think we really need, I hate to sound like Dr. Fauci, but actually he's good to sound like, because he's right. We need a lot more data before we trust blood tests, before we trust any experimental medicines. We really need to collect it scientifically.
Rachel, I know we're at 9 o'clock. Many
I'm
people
sorry.
drop off, but is it possible for us to keep going for a while with some more questions?
Yeah, I believe so. We do have a few more questions left.
Great.
Dr. Keller, want to present, or did I step on your time?
No, I'm good. Keep going. I'm not really presenting much of anything. I'm shooting my mouth off. I don't know.
And this is just a reminder to all the panelists, if you're not talking, if you can mute yourself so we can hear who is talking, that would be great. Thank you guys so much.
So another interesting question we had is, are there any particular IDD conditions that would put a patient at higher risk?
Can I answer that?
Yes, please.
And this is actually a segue to my next presentation. I'll be doing the next presentation. I specialize in geriatrics, so my attention is towards those aging. And my talk is going to be related to people with early onset Alzheimer's disease and Down syndrome, people that are having respiratory issues, and certainly Jeff, you had mentioned actually about people that are functionally impaired, swallowing dysfunction, immunocompromised. Those that have Alzheimer's disease, swallowing dysfunction, a weaker generalized state, obviously older are at much risk. I won't give it all away, but basically, no doubt. And I do also treat a lot of people with cerebral palsy who have a fair amount of pulmonary complaints and swallowing dysfunction. So I really do think that whether or not the data is there, I think we have to really be appreciative of the population that we feel are in a weakened state, immunocompromised, swallowing dysfunction, gait dysfunction, falls, those kinds of things, where they're at risk of having a lot of colds, risk of flu. I really think that's a high population that we have to worry about.
Yeah, I think that's right. I think it makes sense that it's the same as the influenza risks.
Absolutely.
No one has really understood why, for example, obesity is an influenza risk, but it may be, chest cage, thoracic mechanics of breathing. Certainly neurologic disease, as you point out, has problems with clearing the airway, with secretion control. Down children and adults with Down syndrome or trisomy 21, some of them are thought to have some mild immunodeficiency that usually doesn't that may lead them to have more frequent upper respiratory tract infections, viral infections. Usually doesn't come to a point that they need chronic antibiotics or immunoglobulin replacement. But having said that, some folks do, and they probably would be at more risk of this. But again, we have to separate out. It's not that their development or their developmental delay or intellectual delay may not actually make them get more infected or more likely to be infected. It's that if they get infected, they get more seriously ill. So that to the extent we can do social distancing and mask and hand washing, which of course in and of itself may be hard when you have IDD or when you're in a care facility, then you can be protected. So it's not like it seeks them out in the community more than another child or another adult. It's just the complications are worse and it's harder for their bodies to recover.
There are other developmental disability conditions that also have increased risk. Dr. Weinberg mentioned earlier people with underlying respiratory challenges. So some people with severe cerebral palsy or even spina bifida might have chest wall limitations that would put them at higher risk of serious illness should they catch the coronavirus. People with the DeGeorge sequence, 22q deletion syndrome, have immune differences as well as
absolutely
differences as well as cardiac problems that can put them at higher risk of serious illness. So there are lots of conditions that happen to have developmental disability as part of them that also can increase the risk because of medical reasons that happen to go along with those conditions.
And what also happens to those that have innate behavioral difficulties about them in this? I mean, we can talk a whole 50 hours on that issue. For those that have behavioral issues as a baseline, what happens to them during COVID-19, social isolation, quarantine, adhering to rules and regulations. God forbid they get sick and have to go into the hospital. I mean, do the math, do the stories. I mean, we have almost 500 plus people on the call. We probably could go around and talk about this. It's insane. It's really crazy. And I think we're going to have a lot of mental health issues, both by the people with IDD, their families, the staff, the organizations. We're all kind of pulling our hair out about what's going to happen. And when the dust settles, what are we going to be left with? So we really are going to be focusing and talking a lot about this in future conversations.
Yeah, it's actually too bad that none of us, well, it's good that none of us are 100 plus years old, but it's too, there wasn't much written about that after the great 1918, 1919 influenza pandemic. And yeah, they didn't have social media and they didn't have the internet, but it must have been a hell of a stress then too. And I realize that people with IDD may not have had as long survival for many reasons then, but you would think there must have been, I mean, similar to survivor guilt after the wars or after, I mean, there must have been a lot of mental stress in the 20s. Maybe that's why the 20s went bizarre with the Roaring 20s, because everybody just wanted to party after they survived. But you're right, and it's hard to know how that will translate to the modern era now.
Steph, what does stress do to the immune system? If your cortisol levels and other, what does stress do just internally to fight off infections? I mean, I don't know much about it. I'm just throwing that out there.
I don't know much about it either, but I'm very much a believer in the science of neuropsychoimmunology. There's a lot of connections. Things like irritable bowel syndrome that, when you get upset, even if you don't feel upset, your bowel gets upset. But I can imagine there may be things that we have to find out or study in that realm. It also, the critical care people are telling me that they're changing their sedatives and the different types of sedatives or medications when people are on ventilators, and clearly those, we all know that some of those cause problems in the ICU.
I've been cued to make and to add another comment here that that it actually was Special Olympics that nudged the CDC to start collecting data about people with developmental disabilities, and that actually more people with intellectual disability have been reported to Special Olympics than have been published yet in other groups. So that was a message to us from Alicia Bazzano, member of our group who now works for Special Olympics and is sitting on top of the data. So we will hear more from her. Perhaps, Seth, you can share some updates from Alicia in your presentation next time.
I look forward to it, yes.
Yeah. I was going to also ask, I was also going to make a point that so many of us, all of us, are feeling anxious. You talked about the behavioral implications. Everybody feels anxious and out of control, in these days. And giving people things that they can control is a way to help people to focus on the things they need to focus on. So giving people activities that they can that they feel are more nearly routine helps to reduce the anxiety and helps everybody to be able to be more comfortable wearing a mask, to be more comfortable with distancing, etc. So giving people things that they can feel in control of is sort of a basic behavioral strategy.
Right. And some of those some references, the substance abuse and mental health booklet, the SAMHSA book, and some of the other websites do have, in there talking to, and mostly, I'm sorry, they're all for children because I'm a pediatrician, but they're in terms of talking to children about trauma or stressful events or disasters on TV. They make that point to, you have to be in between. You don't tell them everything. Oh my God, some guy with a machine gun just took out 50 people. Look at all that blood. But no, you say, there are bad people in the world and something happens and, it's not going to happen to you. And you talk about, and there are various strategies for that so that you can get information, but somewhat feel in control.
Rachel, can you give us another question?
Yeah.
Yeah, so I have just one last question from Alicia Bazzano. Are there ICD-10 codes for COVID? Other than states sending cases to CDC, are there other means?
They are in the works, I believe. I don't know them off the top of my head. I saw something about the ICD-10 codes coming out. Actually, we're behind in this country. I also saw a paper about ICD-11. I think Europe's already on the ICD-11. They were on ICD-10 when we were back pre-ICD-9. So I'm sure codes will come out. As Steve and Seth would know, and Rachel, as you're learning as a medical student, it's up to us to do the right coding in the charts. And even today, that's not always happening. So you're right. Data collection is premier. In the middle of a crisis like COVID, if I was in New York hospital taking care of hundreds of adults, it wouldn't be my first priority to make sure that I had the right code on the right chart, because I would probably be taking care of too many people trying to keep them alive. But as things quiet down, we certainly need to go back and look and start having the medical record coders code things correctly so that we can learn.
We're catching up in our practice, and I'm in Southern New Jersey. We're actually coding, and it's really, and we could have a whole talk on telehealth, and I'm going to be speaking about telehealth during my presentation, relation to COVID-19 coding and data that has to be into the records. And really what it is it's partly related to accuracy of information, but also related to reimbursement for visits. So there is a practical and a reality.
Yes.
But I will be speaking more about this in terms of access and quality to healthcare services during this dreadful time, like how are we even caring for people when we're having social distancing in our practices? So how are we doing it? How are we conducting it? So, the story is still being written, but, we're working hard to play catch up and we're trying to do the best we can. And I'm going to talk about that more.
And when is that talk? We should.
April 22nd, Wednesday.
All right. So everybody sign up. Wait. Wednesday. Yeah, there it is. Wednesday. I just
April
looked and the
22nd.
slide changed. Wednesday, April 22nd.
Yeah, but we're catching up. And one comment that I just like to make is that the one thing, I hate to say it, there's a silver lining to a dreadful pandemic, is that one thing that I think all of us we're seeing here, we have all these people on the call. Each of you, I'm sure, I don't know who all these 500 people are, but we care. We're all advocates. We're very strong advocacy-run people working in the field. We all know that. We have our friends, we neighbors, our colleagues, we have our organizations. So I think really what it is, we're leaning upon each other more and more to care for each other, to be watchful for each other, to provide best practices in care. And I think that's something that I think is important that we continue to do and not let up.
Yes, I think the whole country is starting to show a little more humanity than has been in past years. And if there's any
trust but verified, Jeff.
if there's if there's trauma, that it at least brings us together a little bit. But
what can I say?
yeah, I have big hopes that that the medical care system and things might actually be spark enough to reform some things, but we'll have to.
Yeah, I hope so.
Thank you. I think that was a great way to wrap it up on kind of a positive note. I'd just like to thank Dr. Weinberg again, and also mention that any questions that we didn't get to, we'll have posted on our website. And then I'd also like to thank University of Pacific's Arthur A. Dugani School of Dentistry in San Francisco for making this webinar possible. And remember to tune in April 22nd for our Part 2 featuring Dr. Seth Keller.
And I'm going to add one plug, remind people that if you liked what we're doing here, consider joining our organization or making a donation. We would really appreciate your being part of us. Thank you.
Thank you
Guys so much.